Say your name so I can pronounce it correctly. Let me try. Is it Dr. Lourdes?
Yes, Lourdes, that's fine.
Oh, I did say it. Did I say it right though?
Yes, you
Okay,
said.
perfect.
You were correct.
All right, so we met at the ISSWSH conference, 2023 ISSWSH conference in St. Louis. Could you please tell me your title?
Okay, I am an MD and a MBA and a fellow for the ISSWSH,
Okay,
the conference, yes, and a certified sexuality counselor for the AASECT, the
perfect.
American Institute, yes,
Okay,
the AASECT.
AASECT is the American Association for Sexuality Educators, Counselors, and Therapists, right?
You know it better than I.
I have to memorize a lot of acronyms. um,
So,
okay, great. So, my first question for you, I guess, would be what is stigma? Let's start there. Stigma with sex, sexual health. What does that mean to you in your experience?
well, it will be a prejudice. It will be a judgmental thought about a person before you actually know whatever is happening.
Okay. And
Yeah.
do
Or
you,
what the person is in reality. Yeah.
okay. And
Mhm.
do you see that stigma in your work?
Yes. I think the stigma is everywhere. I mean, there is no place or no population without, some kind of prejudice or, yeah, this, it's like racism. We both are familiar with that. I'm from Mexico, you being a black person. So we are familiar with that. It's there somehow. It's something like that, I think.
Okay. Are,
Yeah.
are there any situations that you see stigma more? And what I mean by that is when it comes to sexual health, if it comes to like COVID or the flu or with mental health. Can you tell me like just where you might see that stigma is most prevalent in your work?
Probably towards criminals.
Tor-
Probably.
Towards who?
Criminals.
Criminals? Ooh, okay.
Yeah.
Can you
I
explain
think
that for
that
me?
I think that sometimes, because as physicians we should take care of every person regardless of whatever. And sometimes, I seen some hesitation, in regards of criminals that we say, mm, maybe I shouldn't be as professional as I should. Something like that. We usually say those type of things out loud. That's the good thing about physicians. And it's also a bad thing because it can be interpreted in a bad way.
Okay.
But usually, just to let the things out so we hear ourselves and we correct ourselves. That's very common among physicians that we say a lot of things out loud, and sometimes we recognize that we need to do better because sometimes we don't see that people who are not familiar with this environment, saying out loud things to reconsider thoughts, help us to reconstruct and make a strategy in regard of whatever we are going to do. Because it's what we do.
Okay.
When we are trained, we say out loud, the patient has this, and that. And then the reasoning, works that way.
So it's just
So,
the process of processing.
yes. And but it can be, very rude, or I don't know how to. It can be seen by other people, that say, maybe I shouldn't care. Maybe I shouldn't did this because the patient is an assassin or something like that,
Okay.
uh, a shooter or
That's
You
what I
know,
was thinking. I remember I don't watch a lot of TV, but I remember seeing like a medical show. It was like Chicago Med or Chicago PD or something like that, or Grey's Anatomy. Uh, I don't know which one, but there was an episode where a gunman who had killed or shot someone close to one of the surgeons who had to treat this person, and they had an internal conflict of, well, I should just let this person die, or, I'm supposed to save everybody. So that line of ethics and integrity is clearly right there, and in that situation, you may not have any judgment for the surgeon if they were to really just let that person die. Like, yeah, they should do their job, but would you blame them? No, probably not nearly as much as if it were a kid. And I don't know. Well, there wouldn't be any association with a criminal, but like a kid who stole a candy bar from a store and ran away, tripped, fell, and broke an arm, right? It would be a completely different. So uh, we should treat everyone. And while
mm,
these are two completely different situations, we should still see both of these patients the same as people who need to be treated. Is that accurate?
and that's it. And that's it. Yes, and that's it. And what I was referring to is that the problem is that we do this process out loud. That's typical. That's the way it is. And from other people who is not familiar with our processing,
Ooh, okay.
can mean that we are, rejecting or unable to perform our job. But it's just the processing. But we show with that situation that we are humans. I mean, we are as any other person, and we are faulty. And that's the reason I think that it is good for physicians that we do this. We say things out loud
Okay.
among physicians. Yeah.
Yeah, thank you for sharing that. Um,
Mm.
Now, criminals is one place where we may see this stigma in a sense of being prejudiced. I like that you use that definition because depending on who you ask, different people will say stigma is a different thing. For me,
Oh yeah.
I would say stereotype and prejudice,
Yes.
whatever the words are, they eventually will come back together scenario to scenario. So I would say stereotyping a one individual person based off of a collection of information that you may have about a particular subject. So an example here would be a gunshot victim. Okay, so
Mhm.
in St. Louis, where I'm from, there's a lot of gunshot victims, and it's typically in condensed areas of town. So it will be assumed that you're in that area, you're from that area, that you shouldn't have been involved with whatever you were involved with. So there's a way that people or the healthcare providers will talk to you, the way that they will treat you, and that can create barriers of resistance from them being able to get all of the information necessary in order to not just treat them, but to also offer potential resources to help them not be back in that same situation if it is an environmental factor. So I want to thank you for that because it made me think a little bit bigger as you were talking through the prejudice of criminals and looking at stigma from a different perspective, because I only look at it from a
But
sexual.
there is not much difference with stereotyping. There is not much difference. It is pretty much the same.
Mhm.
If you consider what we were saying is being judgmental about a person, and from that preventing the um, professional care that we should provide.
Okay.
So in a sense, it's pretty much the same. It's
Yes. Yes.
at the end.
Okay. Now we say that we say things out loud for processing. So people should understand that, we are human And as we're saying things out loud, we're processing so that we can help. And some of that processing may come off as being rude. But it's a good thing because it's helping you, but it's a bad thing because it's raw thought and it's not completely processed. Do you have an idea of what a solution to that may be? Because I wouldn't want you to not process and keep things in your mind and be thinking to yourself. And I also wouldn't want for you to be rude and say things out loud so they conflict with one another. So when we look at stigma as a prejudice, how can we reduce the prejudice? How can we get rid of this stigma in this particular setting if this is one of the things that's necessary to help with treatment, but it also can harm the effectiveness of treatment?
Education is what I take to my residents. Education is what we need. For example, one of the lectures is in regard of BDSM practices. And if we don't are able to, you can see bruises in a body. I explain this to my physicians. And if you are not open to the possibility that the patient actually enjoys this in a way, or you start saying out loud, some questions that can be biased toward sounding, stereotyping or being judgmental, the patient is going to cross any information. It's not going to provide the information that we need to actually provide the health that the patient requires. And it is the same for all the STIs and all the abortion issues, all the things related to sexuality. Because it is important that we do, but the processing, that the reasoning process that I was sharing with you is not something that we say in front of patients. We shouldn't. Sometimes, yes, that escapes because we are humans, but usually we don't do that in front of a patient. In front of a patient, we question, inquire, interview. So what I teach is to formulate the proper questioning required for us to get the information needed so we can provide the best care that we can. If the patient doesn't open up with us, the chances, the probabilities that I am going to make a mistake in regard of treatment increases. Okay. If the patient gives me the information, the probabilities of me being correct and right in regard of the care that I'm going to provide increases. So,
thank you. So we're looking at interview skills, essentially. Like, how can we comfortably, confidently interview a patient in order to get the information that we need in order to offer the best kind of treatment. Is that accurate?
Yeah.
Okay.
Yes, that's correct. And it's not easy because, for example, what type of sex do you have? Do you use condoms? Are you using drugs? How many, partners have you had this last 6 months? And things that are uncomfortable for everybody involved in the inquiry, not only for the patient, even for physicians, because physicians also have a culture, a religion, a belief, a set of ethics in their personal lives. And sometimes hearing another person who behaves in a completely different way, triggers all of those buttons that we have from our education culture morals and all of that. So we need to be really conscious about that. And if you are young or, starting, the inquiring learning process to gather the information that you require, chances are that you're going to make mistakes. I still do mistakes. I mean, I'm an expert, and I still, make mistakes, obviously, after 40 years. Yeah.
Okay. That makes me think. So I work part-time as a standardized patient, and part of my job is working with medical students through this interview process and sharing with them how they make me feel to be their patient. And a lot of the questions that they have to ask, like especially early on, they just want to get it right. So it's very textbook. And so sometimes it's offering them new ways of asking questions, new ways of
How do you do? How do you do? Share that with me.
yeah. So let's see. One that comes to mind is how many sexual partners do you have? I absolutely hate that question, and I don't think that it's relevant. Or have you had, like, throughout your life? So if I've been tested, like, I think it's more important or more useful to know if I've had any partners without barriers since my last STI screening. And you can see, like, their eyes light up. They're like, oh, that makes much more sense, because it may give you, who knows what types of life cycle changes I've had throughout my entirety of my sex life. But if you know what's relevant to my most relevant needed treatment, I think that it would be, okay, since my last screening, I had one partner without barriers. Or, I mean, I could have had like 1,000 with barriers, but the risk is significantly different because of barrier use versus not non-barrier use. So that would kind of send whatever your follow-up questions are in different directions. So that being like a particular question versus like what kind of sex do you have? I'll ask, like, what do you mean? Like, in this location, in this place? Because a lot of times when we're asking about sex, I think that the question is really about intercourse. So I think that we have to more creatively and open-endedly inquire even after we have built some type of rapport with the patient, and make sure that they are comfortable enough in sharing more details about their sex life. But we also have to be more comfortable with hearing what we might hear about a person's sex life, because there could be some things that, like you said, may conflict with our bias, religion, ethics, values, and things like that, but we can't put that onto the healthcare provider. So when it comes to the questioning and interview process, I often offer this formula of meeting whatever information is shared with gratitude and curiosity. Oh, thank you for sharing that. Can you tell me more? If someone were to ask a specific question about my sex life. So I know you asked, how I do it, and I think it's very situational. But to give another example, a question would be, I don't know. I don't. I hate that I'm drawing a blank right now. Nothing's like coming off the top of my head that isn't necessarily sex related, but it's often the sex related questions that I see that there's a little bit of judgment, unless there's like a case where there's kids involved or there's drugs involved. Ooh, perfect. I got one now. Drugs. Do you smoke? Or do you drink any alcohol? I think that when these questions kind of come from out of nowhere and we don't preface it with something, that it makes me a little more unlikely to answer the question. So what I offer for the students is to preface questions that seem unrelated to the chief complaint in a way that will allow for me to be like, oh, well, this might be related. Let me tell you the truth. So instead of, do you use drugs? Do you drink alcohol? For it to be, all right, hey, I know you said you came in here for some stomach pain. So I'm going to ask you a few questions that may seem unrelated, but ultimately they could be what's contributing to your symptoms. Is that okay with you? Oh, okay. And what I'm going to think as the patient is, whatever they asked me might be related to this pain, and it might help them with giving me the right medication, whatever. So when you then ask me whether or not I drink, and I say yes, and then you ask me, about how often do you drink, I'm going to be more likely to give you the real answer. I drink every day. I have a pint of whiskey when I get home from work and a beer. I'm going to be more likely to tell you that without the fear of being judged or stigmatized as an alcoholic. And then how you respond to that based on my discomfort or comfort as a patient may be with curiosity or gratitude, curiosity. Thank you for sharing that. Is this, on a regular basis? Like, what is this every day? How often do you do this? Or did you notice that when you were drinking that your stomach pain started? And you can begin to do it in that way. And I have a little bit of a struggle there, because on one hand, you're expected to learn so much, retain so much, also solve the problem, but you also have to be good at interviewing and do all of these little itty bitty teeny tiny things that aren't really taught in school, that aren't really science based. So I have more empathy for the healthcare providers, the medical students that are expected to know so much, and then they get in the room with me and they may say something that's so small, but it will throw off the entirety of their ability to provide treatment to this patient. So it's a balance. It's a huge balance.
It is. It is. And is something that you need to practice on a regular basis to be able to improve your expertise. And the other thing that I do is put my own residents to interview each other, and that's always funny and very useful, because they know each other, but they can see easily the barriers, to ask the questions, the proper questions that you are looking for. It's important to understand that not all of the visits, the clinic visits, are scenarios for inquiring about sex. You have to wait for the right time. Usually the annual check, or if something related to the condition is there, patient who comes with something in particular that is related to actual, an infection or something related to the sexuality itself. So that's a proper moment, to try to inquire more or go further. But the confidence should be built. It's something that you are going to get toward different sessions. It's not just in the first one, when the patient finally opens up in regard of something that is, unless the patient comes asking directly for something, well, you will get it from the patient. But if something that is hidden, because usually people are secretive, we don't want to say about our practices or desires or anything. We are secretive in regard of sex. Why you are asking me this? And when a patient says, I remember a patient complaining about being questioned, like from the church. And I told him, it was not me who was doing the interview, it was a resident. And I explained to the patient that how sometimes questions out of nowhere trigger us from something that happened in the past. And I apologized, obviously. And I explained to him the reason for the questioning. And he understood. People understand. I don't think that people are idiots or ignorance in any way or sense. I believe that we all understand if we receive the proper information.
Okay. I know we are coming up on a half hour mark, and I want to be mindful of your time. So, do you mind if I just ask you like one more question, and
Yes,
then we can begin to close out?
yes, of course.
Perfect. Thank you. Okay, so going through what I have so far, we've defined stigma as prejudice, and where you see it most prevalent in the healthcare field is with criminals. And there is a code of ethics that we should take care of everyone. So whether that criminal is an adult who's murdered people, or if it's a kid who stole a candy bar, fell, broke their arm, running away from the store that they were stealing from, they deserve to be viewed the same and treated as best as we can. Um, we often say things out loud in order to hear ourselves and in order to process information. That's what's useful to us. And this can be seen as rude if, it's heard by someone else. But on the other hand, it's how we process. The solution to what we're deeming to be stigma as it relates to prejudice is going to be education. An example that you gave from that, from the, wait, this was separate. I just wrote it next to each other. But we talked about like BDSM practices and a person's own openness to the patient being able to share, hey, that maybe some of these bruises are consensual, and this is something that a person may enjoy about their sex life. So when we look at that openness, it also applies to STIs, it applies to abortions, it applies to sexuality. So really what we need here is not just education, but also practice. So I'm thinking practice, education through the practice of formatting these interview questions. We want to understand that how a person asks a question is going to be really critical in the information that they get. And one of the big challenges here, that's probably my biggest takeaway, is that patients too can be very secretive, and they may want to know, oh, why are you asking me that? Why are you asking me this? How is this even important to it? So this is what I have so far. And now my question to you is, as I move forward and I speak with more healthcare providers, what I'm going to do is, sort of map this out and look for common patterns and themes. And then I'm going to distill this into some sort of a survey that can be conducted so that I can see what the healthcare providers need. What is something that, based on our conversation today, you would like for me to know as I move forward with this project that I'm working on?
But let me understand your.
Oh, say that one more time. I'm sorry.
Let me understand better your project. Your project is towards healthcare providers, or
Yes.
can you clarify?
Yes.
Can you give me more information in that regard?
So,
what is your project?
So this project will be taking what I've learned over the last 6 years of interviewing people who have been diagnosed with an STI, and they said that their healthcare providers didn't do a good job. That is very vague, and it doesn't help with coming up with any sort of solution. So I have ideas of what that looks like, and it typically revolves around stigma that they may have faced from a healthcare provider. So what I want to do is understand where and why and how stigma play a role in the healthcare providers workplace field, and come up with a solution there that I can sort of bring to the middle point from where the patient and provider meets, so that I can help with giving more understanding of the prevalence of stigma and show patients what they can do in order to alleviate stigma, and providers what they can do to alleviate stigma, so that there is just less stigma prevalent when healthcare providers and patients meet. Did that make sense? Because I'm still trying to formulate this in a concise way, but I'm basically interviewing healthcare providers to see what the problem, and I hate using this phrase for lack of a better word, what the problem is with stigma in the healthcare field, because I have more of an understanding now of what it is when it comes to patients, and it typically revolves around like sex and any sort of preconceived notions about a person who tests positive for an STI.
Okay. What is triggering me is that I have the impression that you assume that every physician is prejudiced. And I don't think that that's the case.
No.
And I also believe that is not what you are in thinking. I know that you believe, as I do, that there is a problem that we need to solve. But first, we need to consider, I think, that you need to consider how often the problem emerges, how happen, because it can be different according to the situation, according to the specialties. For example, a family practitioner is going to interview a patient from a perspective completely different from an oncologist or a surgeon or a psychiatrist. So don't assume that the inquiring is the same across the spectrum of physicians. So this is not a goal. You have different scenarios. This is what I see. This is my reality. When I train family practitioners, it's a different situation than when I train urologists or when I train oncologists, people who only cares in regard of breast cancer, or this is a different, completely scenario. A lot of oncologists never going to ask in regard of the sexuality of the patient. It shouldn't be that way. They should also take care, but no in the same way. Because we physicians, we rely on each other. For example, what I say to an oncologist, just to give you a clear example, that the woman who suffered a hysterectomy because of cancer, ovarian cancer or uterine cancer, cervical cancer, and required the removal of the organs, now is complaining of painful sex and all of that. So at least what you should do is to refer the patient to the proper professional. Is what we do. So the oncologist is not going to inquire, much. But at least to keep in mind, they should have in mind that the patient may have, or for sure, in some cases, when we treat with certain hormones, the patient is going to develop atrophy, vaginal atrophy, and a lot of the conditions that is going to be the reason for painful sex. So that's the education for oncologists. Hey, be aware and send the patient to the gynecologist. Or, you are treating the patient for prostate cancer. He may develop, or he is going to develop, erectile dysfunction. Send the patient for rehabilitation of the erectile function. That's what I do for oncologists. But it will be completely different for a family practitioner. You know what I mean? So you have in front of you different goals, not just one goal.
Thank
Keep
you.
that in mind.
Yeah, so I wrote down, so what I want to repeat back what I heard. So essentially, as I'm conducting all of these interviews with different people, I need to understand, or I'm sorry, let me rephrase that. The work that's been done to this point, interviewing the patients, what I have to take into consideration is where they might have gone for certain types of treatment, and maybe the person that they saw was speaking to them, treating them from a lens of their profession. So a family physician, an emergency room nurse, a urologist, someone who's regularly even working with people in regards to sexual health. These are just 4 different perspectives of going into the conversations about sex, and each of these people is going to have a different experience level with talking about sex. So what we would want to do is be mindful of where we're going for treatment about our sexual health care or healthcare in general, because we may feel like we got bad treatment, or we weren't treated properly for something, or we didn't get the answers that we wanted from the wrong kind of doctor. Not wrong, but from someone who may
It is the wrong doctor.
Oh,
Yeah,
okay.
it is. You cannot ask about cardiologic symptoms to an oncologist, or maybe he's going to know something, but it's not the proper path, for you to get the answers that you are looking for. So I think that is important for us to educate patients, people, the population, who is the one to ask.
That's it.
Yeah.
I think that's where we can close out at, knowing who to ask.
Yeah.
This was really helpful, and I thank you for being my first on this, because I'm still trying to formulate it and put it together in a way that I can communicate it. But this was really good experience for me, being able to move forward and do this, and I will keep you in the loop. I'm not gonna email you every day about what's happening, but once this project has its foundation, I'll touch base with you again, and then of course once it's done, I'll share with you the finished product. So I thank you so much for your time today.
Yes.
And being willing to connect, and for all that you shared.
And I do have some questionnaires that you may use, and I can share with you. Yeah. Yes, of course, in regard of education for both the physician and the patient. Yes, we will do that. Let's keep this in 2 weeks or something, if you agree.
Yes.
We can do that.
Yes,
All
I would love that. Thank you so much, Dr. Lourdes.
Yes.
You have a great
day. It was really good. See you, Connie.
Thank you.
Bye-bye. Bye-bye.
Oh, shit. Oh, I was supposed to stop this. That was good.